I'm going to start actually talking about this presentation. Is what I call the filler fatigue. I don't know if you have seen, you probably have your patients in which you keep injecting fillers every 6 months, every year. What is actually happening is that the patients actually are getting fatigued, they are getting tired. One of the options is actually to offer them, because they don't know really, it's a lack of education, to talk about what is called the nano-fat, microfat procedures, in which basically anybody actually can do that procedure. Implies to do a mini liposuction without general anesthesia and then process the fat. I'm going to show you exactly how the whole process actually happens. Okay, so here we got our patient. This is a combination. You probably recognize the patient, by the way. So this is a combination actually of a PRGF and exosomes. Like on her, what I did, if you notice, she has a depression here. So I did a little bit of an eyebrow lift. The pretemporal areas actually are diminished. And if you notice, right here, this is becoming hollow as well. And also she has lost volume on her mid-face. You notice also the nasolabials actually becoming deeper, and also the OC right here is also becoming deeper, okay? So the beauty of the treatment compared to fillers is that when you inject the filler, for example, you're going to see the result almost immediately on the table, but then as the weeks pass by, the filler is going to start actually being absorbed. This one is totally different. Here is the opposite. So once you do the procedure, in between 6 to 8 weeks, patient starts seeing improvement. Most of the time, like by 4 weeks. And then every, let's say like 12 weeks, you are going to see more. Then 7 months, 8 months, you are going to see more, and then a year. So the treatment actually in 2, 3 years, we got sequence of patients that I had done 5 years ago, and they still keep the effect of the nano-fat procedure. So you see the profile picture, as you could see the improvement also. And again, this will continue improving. Okay, so let's talk a little bit about the history of fat grafting. What is nano-fat, what is microfat, and also the regenerative properties of the fat. People believe that the fat transfer and all that is something new, but in reality, in World War I, 1915, actually what described a fat transfer in soldiers that have a big wounds. Actually, you can do that procedure too. Let's say, I don't know if you do pressure ulcers. If the pressure ulcer is not infected, very simple. You just inject some of the microfat or nanofat or even direct fat into the tissue. But the bottom line is, what is nanofat? Actually, it came from Dr. Tonari in 2013, and he introduced the name of a nanofat, okay, which in reality is more like I don't know, like a marketing name, because in reality, when you measure nanofat, it's a billion of a billion, right, that you are counting. So it could be like the name really doesn't apply. But again, that's a nice name, nanofat, microfat. So when you say that the patient is getting nanofat, what you are saying is that the architecture of the fat actually is not there anymore, right? So basically you are getting stromal cells. Meaning by that is SVF, stromal vascular fraction. But remember, don't use the name SVF, because when you say SVF to the FDA, it's like you are using an enzyme, like a collagenase. So just use, we call it cell-assisted fat transfer, right? So avoid the name SVF. You see what I was saying about the name nanofat and all that, okay? But the most important thing really is that you are injecting into the patient is stromal cells, right? So the way that I do, I'm going to describe exactly how I do the layers. I call it the lasagna protocol, because It will be like a different layers that will go from the top all the way up, okay? This is very important because actually still these days, most of the doctor who does the fat transfer, they do this, okay? So what happens when you take a big cluster of fat, every patient is going to have some type of necrosis, okay? So, but what happened here is that this is a large a fat cluster, right? And you can see here the necrosis, right? But in the nano fat, really almost the patient, you really don't see necrosis, which is a big thing, especially on the fat. And also you don't see like a decalcification that can happen with the traditional fat transfer. I don't know if you have seen patients that they have done fat transfer to the face, and all of a sudden they develop what is called like a nodules, or basically what it is saponification. It's a Latin name, saponification of the fat, in which basically the fat calcifies, so it will be visible. With the nano fat, you don't see that. If you are injecting only nano fat, actually you won't see these problems, because then you have to go back and try to break up all the calcifications. One of the things that happen with the nano fat is you can see right here, look at the vascularization. Okay, so this is very, very important because this is like I'm doing, I don't know, an organ transplant. So you need the fat to have a good vascularity. This is the concept actually when you do a fat transfer, traditional fat transfer. If you notice here, the adipocyte, this is what is called the surviving zone, okay? So all the adipocytes actually survive. The one right here in the middle is what is called the regenerative zone, right? So basically that's the one that contains the stem cells. And the one in the center is the necrotic zone, okay? All the adipocytes die. That's why I said that every fat transfer is going to be, the patient is going to have some type of necrosis. One of the good things about the nano fat, when we say nano fat, what happens is that you remove the fat, right, through a mini liposuction. And for the face, most of the time, you only need 40, 50 cc's of fat, okay? And like I said before, basically it's not only a stromal cell that you are injecting, but also growth factors, cytokines, right, and the microvascular content, which is very, very important. Actually, you can use the same process not only on the face, but if you are injecting a knee or a joint, you can do the same exact process. So you can have, this is multifunctional, what I'm going to be describing right now. You can put it on patients with hair loss, also a patient with scars. So there are more acne scars. I do a lot of patients between 20s and 30s. I do the subcision for the acne scars, and then I put the layers of the nano fat and microfat. So you can, I mean, there are multiple uses doing this nano fat procedure.
Is there a risk of vascular occlusion?
Very good question. It's very rare because, like I said before, if you are injecting only nano fat, what you will see is a liquid component. There is not really, depending on how you take the fat, if you put it through a filter or if you put it through an adinizer. If you put it through an adinizer, you are going to have some architecture actually still left. That's a very good question. Actually, it has happened, but really it didn't happen with the nano fat. It happened in Europe, but it happened with the fat, the cluster being too big. Okay, but yes, that's a potential complication. Again, this is what I was saying before. When you use an enzyme, you take the fat, put an enzyme, collagenase, and this is what happens. You get here the pellets, right? It's a very tiny particle, and this is actually composed of all these, which are regenerative cells. Okay. Something very important too is that when you use the enzyme, what happens is that the enzyme destroys this, the extracellular matrix. Okay. What you want is to preserve the extracellular matrix. All right. Now, for whatever reason that nobody knows, I don't know when you do the traditional collagenase, for whatever reason, the last centrifugation, the pellet actually is preserved and it contains all the good cells. But we don't know exactly why this is preserved, okay? This is what I was saying before, the difference between the mechanical manipulation and the use of an enzyme. Okay, so that's the thing that you have to differentiate enzyme, collagenase, versus this process in which you basically, what we call it mechanical manipulation, in which the fat actually goes through the, let me go through the process again because it's like a 7 steps to comprehend actually how this is actually done. So when you are doing the, what are those factors? One is the size, the technique, or mainly the size of the cannulas, okay, for the aspiration. What we need to look at, or what I want you to remember, when you see in the OR, you see different size of cannulas, okay? So in reality, what is important is the inside of the cannula, okay? Because depending on that, you are going to get the size of the cluster initially, okay? It's like an spaghetti, I call it like an spaghetti that comes out from that cannula. So remember that you have to use always the same, I like protocols in which it could be the same cannulas, but really sometimes what happens many times is that the doctors in the OR, oh, give me a cannula, let me do this. No, you need to use the proper size cannula all the time to reproduce and follow up your patients and see the results. So this is very important. So I use something called the MiniTC, in which basically these cannulas, by the way, they are very fast, okay, because the speed depends on the aspiration, depends also on the number of holes in the cannula, okay? So meaning that if you got a cannula with many, many holes, the aspiration is going to be faster. But the first step is the infiltration of the cannula, okay? Again, I use this one, and the fenestration diameter in this situation is 4 millimeters, okay? The outer diameter is 2.5, and the inner diameter is 2.15. We measure all that because I like to see exactly how the inside of the cannula and the outside the diameter, okay? The infiltration really is not too much important, but what is important, if you look into a different angle, is the patient comfort. So you need to, do a proper infiltration. Okay, I hear all the time, oh, patients in pain and all that. In reality, if you do a proper infiltration, it's simple. It's not really difficult. In the workshop, I will demonstrate how the infiltration is done. It's very simple. Then what is important is the harvesting cannula, right? So the inside. So again, the inner diameter is 2.15, and that will give you a cluster size of 600 to 800 microns, okay? So once you get this from the cannula, what you're going to see, again, like it could be like an spaghetti, okay? So what happens is that you start cutting that spaghetti in different sizes depending on what you're doing, all right? If you're doing just only for cosmetic, are you only doing, let's say, acne scars after the subcision, for example, then you start basically cutting the fat at different sizes. So usually what I do, again, depending on what I'm doing, I can take a first layer on top of the periosteum, right? Like it could be without any processing, without any adinizer. And then the second layer, I could go at 1200 microns. And then a third layer, it could be 600 microns, okay? Remember, by definition, and I'll show you here 2 different criteria, but by definition, nanofat, the cluster size has to be around 600 microns, okay? But remember, what you get, the size is 600 to 800 microns. So, oh, well, this is nanofat. By definition, it might be, but remember, you are getting like an spaghetti. You need to cut that spaghetti in different sizes. Okay. Again, this is the definition. Macrofat, 2.4 millimeters cluster. So this is basically, if you are doing, fat transfer to the glutes, for example, then I don't process the fat. The fat will be directly injected into the glute because you want a size closer for the glutes, okay? For the face, it's different. Microfat, again, you go 2.4, 1.2. Between 2.4 and 1.2 is millifat, microfat between 1.2 and 600 microns, okay? Look at this microfat. Again, nanofat, by definition, is between 400 and 600 microns. So again, I can start with 1200 microns, then I can do another layer of 600 microns, and then at the end, I go intradermally, right? And I finish up the procedure injecting intradermally. It would be like doing a PPD, okay? Like you would see like a mosquito bite. That would be the final layer, okay? Now, by definition, SBF, 10 microns, and exosomes, okay, 30 to 100 microns. Again, this is a different thing, same situation like I described before, okay? Again, one of the advantages of the nanofat is that compared to the mechanic or the enzymatic manipulation is that the stromal aggregate contains less senescent cells. So what you are transferring, even if the patient is old, it would be less senescent cell compared to enzymatic manipulation, which actually that has been established. This is the protocol, the advantages and all that. But let me show you, this is what I mentioned before. This is what you need, basically, basic stuff. You don't need to have an OR, okay? Just a procedure room, right? People are always concerned with the liposuction infection, but in reality, it's very, very rare, okay? The fat contains antimicrobial substances. So here, this is a big case, but basically, I use no general anesthesia even for cases actually of this size. The patient right there is without general anesthesia. Again, what is important is to learn how to infiltrate the area that you are going to remove the fat, which is very simple. It's really a discipline how to do it properly. Okay, this is the spaghetti I was talking about. This spaghetti has to be cut depending on what you are going to be doing. Okay, this is the fat. A very nice fat. So you can inject this fat, like I mentioned before, in the face, on the hands also. Very simple procedure. I do a lot of female stuff, so I inject it actually into the labia majora also. Actually, that's the best way to learn how to do a fat transfer is into the labia majora because it's an empty space there. So when we do the training for the doctors and all that, what I put it in the labia majora first, okay? Because it's a hole, it's a container basically. I mentioned before, on the hands you can do. Okay, so I use, after you get the spaghetti and everything, then you can do what is an adinizer, all right? And again, these adenizers, they come in different sizes. They come in 2,400, 1,200, 800, 600, 400, up to 200 microns. So depending on what you're doing. Okay, I like more the adenizer than the pressure filters, okay, because the pressure filter is like it's a blunt first, compared with this, which is like this. So it's a sharp blade, okay, this one. You see, it's not by pressure, you are cutting the fat. Again, that's a way, an illustration how the fat goes through the filters. And again, this is what I was talking about before, because actually when you do the process, another step that you can do at the end, you can do a centrifugation, and then you are going to get this, actually. It's basically right here is a pellet, okay? So let me show you now the process, okay? How is the procedure done? I don't know how many of you do fillers in your office. You do filler, right? Okay. So remember, I don't know, 20 years ago, we only had one filler, okay? It's the same chemical composition, the same structure, right? So now we got filler, for example, we got filler for the lips, designed specifically for the lips. We got filler for the cheeks, right? We got filler for the nasolabials, for here, because they have changed, adapted. So what I want you to remember is that's the same concept that I apply here. When I cut the fat in different sizes, for example, if I'm going to do the temple area, I'm going to be using more with more structure compared if I'm going to do here under the eyes, right? Because this is the thinnest part of the skin is under the eyes. So there you want to have only pure nano fat, okay? So this is another patient. This picture is probably like 4 weeks, if I remember, okay? So if you notice, this is becoming hollow. Look at the deep line right here, nasolabia. She has lost volume also on the outer molars. Here, this area also have been diminished, and also the temple area. Okay, this is like only 4 weeks. Actually, I saw her just recently, like last week, and she's so happy, and she has seen there's more improvement. Again, like I mentioned before, the picture that I saw her last week, it was at 3 months, and she's like, the patient is very happy. That's what the thing that you notice. You have to educate the patient, of course. This is not a filler. This is a regenerative procedure, which is all this conference is all about. Okay. So the first step I do, I put what is called the tumescent fluid. There's the same fluid that we use for the liposuction, right? I'll be talking more about the tumescent fluid in the workshop and explain how it's made, the normal saline, the composition, and all the differences. What I do, I start infiltrating with the tumescent fluid with a 30 gauge needle, okay? And the patients actually, even before putting the patient in the OR, I start doing that into basically on the areas I'm going to be injecting. For example, in this patient I injected for an eyebrow, temple, mid-face, lower face, and all the areas that I mark here, right? So that's the first step. Second step, again, you do the mini liposuction like I just mentioned before. In this situation, I remove the fat from the outer legs. In women, even if they are very skinny, let's say, for sure you always are going to have fat here on the outer legs, which is actually a very safe area to do. Okay, I know many people are afraid of liposuction, punching organs and all that. It's very rare, really, but those areas like the outer legs or the flanks, this is very simple to do, and you really are not going to find structures that are on your way. So basically, we remove the fat from there. Like I mentioned before, we took 50, that's all you need, 50 ml really. And we pass it through the adinizer, as you can see right now, and I wanted to have a 1200 microns, all right? To start the process, and then 600 microns. So again, like a lasagna, I start with the 1200, then the 600, and then I combine it also with the PRGF. And if you have probably you guys have the difference between PRP and PRGF. I'm going to be mentioning it briefly there as well. And this is the description on that patient, you know, on the cheek, how many mLs, in the subcutaneous space and all that. So this is the detailed report that I do in all the patients. Again, this is what I injected right here, the 600, 1200, and then intradermally as well. Okay, this is a patient with a scaring alopecia. They had done on her everything. I was doing in this patient, by the way, she came for a cosmetic procedure. It was a lipo and fat transfer to the glutes, and then we start talking about this. Well, let me put some nano fat. And this is, you could see it right now, this is probably 3 months. So again, you can use it for the hair too, right? This is a before and after with the nano fat only. And this is, for example, acne scars. So in this patient, you can appreciate here box scars, actually, very severe. And look at the diminished volume. So I did a subcision, and this is just 4 weeks after, okay? Again, he will continue improving after all this. This is another one, before and after. You could see the loss of volume, and now she has recovered actually her volume. You see the changes, 2 months. This is actually another one, acne scars. I do a lot of patients, 20, I like the acne scars because what I don't know in Central Florida, what I find out is that the dermatologists, they don't do subcision. For I don't know exactly the reasons. So I do a lot of patients with the subcision for the acne scars, and really these patients, most of them, they are happy. They are, they don't expect a dramatic improvement, okay? But the good thing with the nanofat compared, if you do a subcision and then you inject, let's say, a hyaluronic filler, the hyaluronic filler will dissolve. This is totally different. It's going to regenerate the area, give you a volume, okay, that is different from the traditional fillers. You could see patients now these days, they have a big cheek, big lips, okay, they don't look natural. And this is for patients also that they don't want, I don't like to make this big cheek with the filler. So I also try to educate the patient about this procedure. So you see the difference between the PRP and PRF. Again, I think it's very confusing because I see all these names and all that. I will try to explain it briefly. So for the PRP, basically you do a high centrifugation. For the PRF, basically it's a low speed centrifugation. So here you get in the PRP, basically the plasma with concentrated platelets. Here you are going to get, it's like a gel, okay? It looks like a between filler actually, a hyaluronic filler, the thickness and the consistency look like that. It's like a gel. So that's something that will give you the volume compared to this, right? So in the PRP, you get immediate release of growth factors, right? Here, it's going to be a gradual release of the growth factors. So sometimes, depending on what I'm doing, I might do a combination of this with this, or I do in one session PRP only, and then the PRF, okay? Again, this is the beauty of the PRP and the growth factors and all that. I use for the PRF, I don't know if you guys do the same or not, but I use what is called the temperature, it's an equipment in which uses, basically you put after the centrifugation of the blood, we put it in that machine, and what it does, it takes like a 45 minutes, actually 40 minutes. It goes by cycles using temperature. But it's a physiologic temperature, different cycles. And then you can get also the fibrin actually clot right there also, which is another step. Again, it depends on what you are going to be doing, okay? So again, this is just a representation of the plated poor plasma on top, medium plasma, plated rich plasma. Again, the plasma is basically 50% water, really. And this is the leukocytes here, and this is red blood cells. So when you centrifuge, this is what you're going to get. Again, this is what I was talking about before, right? The different speeds of the centrifugation, and this is they call it the membrane, or they call it the clot also. So again, all depends on what you are trying to achieve, what is your goal in regards to the treatment. Again, this is what I'm talking about. This is the fibrin actually clot, which actually is used mainly in dental procedures, like a bone graft, stuff like that. That's what, you use that one. Most of the time what we do there in the lab is that we get rid of this because really I don't use it too much. But you can use it, let's say, I don't know, thinking here like a pressure ulcer, for example, you can put this. We're almost done. Again, this is if you have insomnia and you cannot sleep, you can read all this and try to understand this. But basically all these names, because I put this slide here because it's very confusing. People say PRGF, PRF, all these names are making everybody confused. This is very important in the PRF. Look at this cell. They are actually positive for CD34 stem cells and CD61 for platelets and also got cytokines. Okay? We use the calcium gluconate also. I don't know if you use, because I see a lot that people said, oh, centrifuge med spa. Oh, we only centrifuge and that's it. No, you have to activate the platelets. And the way to activate the platelets with the calcium gluconate 10%. Okay? Again, this is the system I was talking about that we have there that uses the temperature. Again, it's longer because it's like a 40 minutes, 45 minutes. This is patients actually with PRGF only. Again, look at the volume improvements with the PRGF. Almost done here. Again, you can see also there, this is in the office, doing some training to the doctors. Thank you so much.